all. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. I hope you had a great weekend. This is an interesting case series from Seattle Children's Hospital. They said that they had some patients who had developed myopericarditis after Pfizer vaccine. And researchers had been then following up with these patients, these children, to see how are their hearts doing. And I think that is a very important study as well for all of us to understand that those patients, children who develop myocarditis or pericarditis, what is their condition after 3 to 8 months or a year or 2 years? What would happen? Are they going to have a scar in their heart forever? And what are the kind of abnormalities that they may have? And how much resolution do they have? So, interesting case series, small study, 35 total patients of myocarditis. Out of them, 16 cases are presented here. So, let's look at it. The summary is the following. They saw even after 3 to 8 months that patients, as much as they resolved, they continue to have cardiac magnetic resonance image abnormalities, and especially longitudinal movement of the heart was not resolved. And secondly, the inflammation or the markers for that were still enhanced, although resolving, but still enhanced. So let's look at it. So I'll go over the references later on. This is drbeen.com. In the description, there is a link to drbeen.com that has huge discounted price for Dr. Bean's access. Now, I want to go over this. So the Journal of Pediatrics is where this case series is published. It is from Seattle's Children's Hospital. I want to read a couple of things before we look at the larger message. So number one, in the discussion here, they say this paragraph, the first paragraph's last sentence, they say, although symptoms were transient and most patients appear to respond to treatment solely with NSAIDs, painkillers, we demonstrated persistence of abnormal findings. We demonstrated persistence of abnormal findings on CMR, cardiac magnetic resonance, at follow-up in most patients, albeit with improvement in extent of LGE. And I would explain what LGE is. So in most patient, so that is one message to keep in mind. Then look at this one. Notably, in our cohort, though there was significant reduction in LGE at follow-up, so LGE is late gadolinium enhancement. It is a marker on imaging for heart to show possibility of edema, scarring, fibrosis, extracellular, outside of the cells problems. So late LGE was reduced after 3 to 8 months, but still present. So notably in our cohort, though there was significant reduction in LGE at follow-up, abnormal strain persisted for the majority of patients at follow-up. So that is very important. Then another sentence here. In a cohort of adolescents with COVID-19 mRNA vaccine-related myopericarditis, a large portion have persistent LGE abnormalities, raising concerns for potential longer-term effect. So then there is some good news here as well. And they say that despite these persistent abnormalities, all patients had rapid clinical improvement and normalization of echocardiographic measures of systolic function. Systole mean when the heart contracts and pushes the blood out of it like a pump. So that is systole. For patients with short acute illness, no dysfunction demonstrated by echocardiograph at presentation and resolution of symptoms at follow-up. Return to sports was guided by normalization of CMR alone. So they are also talking about a specific kind of imaging. Cardiac magnetic resonance alone was sufficient to say you can go back to start playing games. What they're saying is you don't have to do a huge plethora of labs, just CMR was sufficient. So that's a good news. In patients with persistent CMR abnormalities, we performed exercise stress testing prior to sports clearance per myocarditis recommendations. We plan to repeat the CMR after a year. So that is the interesting thing, that majority of the patients started resolving, although all of them, or a majority of them, still had cardiac abnormalities after 3 to 8 months. So now let's look at a little more details that I have drawn. So this is the gifts for humanity, a little tiny broken heart over here, and then let's start. So first, as you saw in the discussion, the last part of the first paragraph, that there is persistence of abnormal findings on magnetic resonance at follow-up in most patients. So what is this case? So case series from Seattle Children's Hospital. The children, these were adolescent, and their ages, look at this, their median age was 15 years. The age range was 12 to 17. These 35 children were 12 to 17, out of which 16 continued to follow up, and so they were present in this case series. 94% were males, and it was primarily after the second dose of Pfizer vaccine that they developed the myocarditis. 88% were whites and non-Hispanic. One Asian, one Native American. The cardiac status was checked 3 to 8 months after, and after the acute myopericarditis. Okay, so continuing. Summary, what did they see? So let me actually show you the diagram to explain what they are talking about. So if you see this diagram, on the left side are the abnormalities that were seen at the acute disease, and on the right side are the resolutions or not after 3 to 8 months. So what is interesting to see here, for example, these arrows. So this is a left ventricle, I believe, and outside of the left ventricle, or the outer layers of the left ventricle, is showing this whitish thing. This could be edema, this could be scarring, this could be congestion. So this is extracellular area and its dynamics. And if you see here on the diagram on the right, majority of that has been resolved, but you can still see some remnants over here. Similarly here in this one, again, this is left ventricle, this one, and here is the white areas that are depicting damage or myocarditis, inflammation, edema. And here it is resolved but not fully. So you can see some dots present still there. Then if you see here, this is also left ventricle, this whole thing, it is sliced, and the whole wall of the left ventricle, especially this area, is more opaque. And over here, it has resolved fully. So there are some parts that were resolved and some not. So now let's look at the data. So echocardiograph, left ventricle ejection fraction. What does that mean? So let's say my left ventricle, when it fills up with the blood, then the ventricle would go in a systole. That means it would contract and it would try to squeeze the blood out of it. So the amount of blood that was present in the ventricle before the pump started squeezing versus the amount of blood that got out, that fraction is called ejection fraction. So left ventricular ejection fraction is normally 55% or more. That is, usually 55% of the blood is ejected from the left ventricle or more. When they saw these patients in the beginning, their left ventricle ejection fraction had gone to 59.4 plus minus 6.4 to 62.6 and plus minus 2.8. So this plus minus 62.6 is after 3 to 8 months. This is at the time of the disease. So if I go back here, left ventricle ejection fraction here. So follow-up CMR left ventricle ejection fraction was 57.7 plus minus 2.8, was significantly improved from initial 54.5. So that was the CMR left ventricle. This was echo. So in the CMR left ventricular ejection fraction, remember we need to have it 55% or better. It was at the acute disease 54.5% median. At the follow-up, it had improved to 57.7%. It did not go above 60 or near 60. It was improving, but not a lot. And then this is very important. CMR LGE. LGE is that opaque areas that we were seeing. That was the late gadolinium enhancement, these enhancements. So this was done in 15 patients. Originally, when they were sick, it was at 13.5 plus minus 8.3. And then it started improving and went down to 7.7. It should have been really near zero. So it was improving but had not fully improved. Similarly, global longitudinal strain, and I would explain that in a second. This is the length of the heart, and when it is beating, how much, what percentage of the length decrease occurred, which helps squeeze the blood out. So normally, usually, about 20% volume length change occurs. More than 18%, 20%, 22%. In these patients, the volume change, the length change actually, had reduced to minus 16. Length change had reduced. And of course, because there is a part of the heart that was damaged or that was inflamed, that was hurting. So heart will not contract fully. This is just like if you have a injury on your hand and I ask you to squeeze hard, you would say, no, I don't want to because it would hurt. So their squeezing or the length reduction itself had been less. And then at the time of follow up, this is the shocking part in this whole discussion, that length reduction was still not recovered. It stayed the same. That is, heart did not reduce in length in a good way or in sufficient way or in normal way. So what does this mean? So if I go in here, imagine this is left ventricle. Imagine left ventricle being a small bucket or a glass, something, and something that you can squeeze to throw the water out. So this is left ventricle. It has, when it first of all, it fills with blood. That is called diastole. It relaxes and allows the blood to come in. So once the blood is poured in and it fills up, then its job is to now squeeze that blood out, and that is the cycle that continues to occur. Now, when the left ventricle squeezes, it squeezes in two ways. Number one, its length reduces. Number two, its diameter reduces. So it squeezes in a circumferential way and it reduces in length. So it shrinks, you can say. When it shrinks, it would pump the blood out, then it would relax again to fill with the new blood, then it would shrink again and pump the blood out. That is the cycle it would continue to do. The length reduction is calculated by looking at the total length at the end of diastole, that is at the end of relaxation, the length of the heart, left ventricle, and the total length at the end of systole when it is pumping. So what you do is you take this total length, let's say length and systole and length and diastole. You take length and systole and then minus length and diastole divided by length and diastole, and you would get the fraction. So this fraction is usually 18%, 19%, 20%, usually in a negative, written negatively. This was reduced in the acute disease and stayed reduced 3 to 8 months after. That is something that was, even authors said that this needs to be observed because there is a possibility. So if I go down here, so in a cohort of adolescents with COVID-19 mRNA vaccine related myopericarditis, a large portion have persisted LGE abnormalities, raising concerns for potential longer term effects. And they talk about the length strain as well. So anyways, now back here, there were some problems that had resolved. For example, EKG had become normal, troponin levels had become normal, C-reactive protein had become normal. However, cardiac structure and functional markers were still showing abnormality. So this is it. We're done with the basic study and what it meant. What is the follow-up? What is the takeaway? Number one, they said that we would continue to follow up with these children to give you more data about it. Number one. Number two, they say that there is a concern for the long-term effects of the vaccine, so we should keep that in our mind. Number three, they said there are some studies that show that the interval between the two doses, if that is increased, then the myocarditis frequency or incidence rate reduces. And they said this is because of this, CDC has actually increased the duration between the two doses to 2 months or 8 weeks. Then they said that it is also interesting to see that CMR, or cardiac magnetic resonance, itself has been functioning or providing value. But what they said was they could not compare if a patient, adult patient of myocardial infarction, has CMR abnormalities. You can think about it from those abnormalities, if they persist, to kind of create a prognosis at what is going to happen to this patient's heart. However, the researchers said for children and for vaccine, we do not know what is the extent of the problem, so we will have to learn more about it. And they said bigger studies are needed about that as well. Another interesting takeaway that I had, I'm trying to finish the summary for you so you can, if you wanted to stop here, you could. Another interesting thing they said was some patients were given NSAIDs, painkillers, non-steroidal anti-inflammatory drugs, and painkillers and anti-inflammatory, and they felt okay within 2-3 days and they were discharged from the hospital. Some patients required corticosteroids plus IVIG. They said this is our protocol for myocarditis in our hospital. One patient only had IVIG. And what is interesting is that those patients that had IVIG plus corticosteroids or only IVIG, there were 3 total patients, 2 of them did not have the LGE abnormalities after 3 to 8 months. And those who were only on NSAIDs continued to show the abnormalities. That means at the time of acute myocarditis because of the vaccine or following a vaccine or associated with the vaccine, they say that IVIG plus corticosteroid had a better outcome. So if I can very quickly show you that as well, because this is practical for the doctors to understand that when they are managing, what is the best way to move forward. So let me show it to you. So the patients, read this one. So there were 3 total patients. 2 patients had IVIG plus corticosteroid. 3 total patients who were managed this way. 2 of them IVIG plus corticosteroids, 1 of them IVIG only. Out of these 3, the patients who received IVIG alone and 1 patient who received IVIG plus corticosteroid had resolution of LGE. That means the markers for cardiac extracellular space, or the fibrosis or cardiac edema, that marker was reduced in them. And the other had persistence of LGE. Everyone else had the persistence of LGE marker, meaning they still showed fibrosis or edema or something over there. Now, we can't say, just looking at the LGE, we cannot say what is happening in the heart. So if you see here, for example, late gadolinium enhancement is a result of regional differences in myocardial extracellular volume and different uptake and washout patterns within the extracellular space, and is seen in myocardial injury, myocyte necrosis, that is death of the heart tissue cell, myocardial edema, presence of the edema or the fluids or congestion, that is also a result of injury to the heart cells, myocardial scar tissue, and focal areas of fibrosis. So they're saying those patients who had IVIG plus corticosteroid or IVIG only did not have LGE on the follow-up, except 1 who had it. All other patients whose condition was milder, who were only given NSAIDs, they actually continue to have LGE positive. So this is an important takeaway for the management of this situation. Okay, so that's about it. That's the discussion. I'm going to go a little more in the details. So Pfizer-BioNTech vaccine, 35 patients, 16 included, the remaining were excluded because either they did not come in for follow-up or their echo was done too late and so on. So they were not within the protocol. Median time to start the myocarditis-related symptoms was within 3 days of the second dose, and the range was 2 to 4 days. So that means in adult male children, after the second dose, 2 to 4 days are very important. If during that time the child complains of chest pain or develops fever or develops shortness of breath, then that is a very important sign to take them to the hospital. Chest pain occurred in all of them. So that is an important sign because it is happening to everyone. And we know that whenever we have cardiac problems, we complain of chest pain. Fever, 6 of them, or 37.5%. Shortness of breath, 6 of them. So chest pain, all of them. That's one. Then serum troponin levels were elevated. Troponin comes out of the damaged heart cells. So within the cell, there are proteins called troponin that are helping with the heart muscle cell contraction. When the muscle cell damages and opens up, it's broken, the guts of the cell are spilled in the blood, and that has troponin, which we can measure, and that tells us the kind of heart attack, the extent of heart attack, the extent of damage, and so on. So troponin level in all these children were increased. That means there was local cardiac muscle tissue damage. Median was 9.5 nanogram per milliliter. Normal is lesser than 0.05, and range was from 0.65 to 18.5. 18.5 will be more damage, 0.65 will be less damage. But they all had the marker for the cardiac muscle damage. C-reactive protein, 12 of them. Remember, this was 16 total. Normal CRP is 0.08 milligram per deciliter, and they had 3.45 or 0 to 6.5. So that is the marker for inflammation. Abnormal EKG was in 10, And the type of abnormality was really the ST segment elevation. ST segment elevation, this means that there is a damage in the cardiac ventricle, and ST segment is related to ventricular repolarization that gets elevated. Long discussion. I actually have these lectures on my plug. I have these lectures on drbeen.com which explain what does ST segment elevation or depression means. So they had ST segment elevation. Reduced left ventricular ejection fraction. So again, out of all the blood present in the left ventricle, what was the fraction that ejected? 2 patients had reduction. So that is a good news actually, that majority of the patient didn't have it. But 2 had the reduction down to 45% and 53%. Again, as I said before, normal is 55% or more. No pericardial effusion, that was good. So the outer, imagine that heart is actually sitting in 2 bags. So there is a bag that actually has 2 layers, and that is the pericardium. And pericardial effusion is when there is so much damage to the heart that the congestion and fluids and these substances, they ooze out and they start collecting in the pericardium, and that is pericardial effusion. So that was not seen, which is a good news. CMR, cardiac magnetic resonance, that is the basic study about. It was abnormal in all of them. Now, what were the kind of damages that were seen for various children? So they said we saw transmural inflammation. That scared me actually. Transmural, mural means wall. Transmural means through the thickness of the wall. So transmural means the whole part of the wall from inside to outside, the whole part was inflamed. If there is a transmural myocardial infarction causing tissue damage, it can actually be, depending upon the extent of it, the size of it, it can be fatal in some cases. So here, hopefully, it was not really a lot of damage or necrosis, but just the inflammation, but the whole thickness in one patchy area of the ventricle. Then they also saw subepicardial edema. What does that mean? So this is the heart's layers from inside out. The most inner layer is called endothelium. That is the layer on which we suspect sometimes the spike proteins can attach. More importantly, autoantibodies can attach. So that is one. This is the internal layer. Then is the muscle layer. This is myocardium. Outside of the muscle layer is the epicardium. So between the epicardium and the muscle, if there is damage and collection of edema and scar and those things, that is called subepicardial inflammation, and that is what was observed as well. So that means the whole length of the heart muscle in some patients, whole, I shouldn't say length, the whole depth or width or thickness of one part of the heart muscle was involved in some. In some children, there was subepicardial area where there was the congestion or edema or fibrosis. Then there is this little space here which is filled with fluid. This is that bag. So bag itself is filled with fluid so that heart can slip in it and kind of beat without any issues. And then is the outer layers, which are the pericardium, parietal, and fibrous. So these are the pericardiums. They saw the issue here and the full depth. So I have already, so they have a figure 1 for the segments. So anyone who is a cardiologist here, of course, you would know much more than I do, but here is a diagram which was very, very interesting. This is a diagram. So this part of the heart is the apex of the ventricle, and these are various zones, and they have actually marked out which part of the wall of the heart was damaged in which children. For example, Here, number 1 is the basal anterior, 0%. But let's see, if you look at 6 is the basal anterolateral. So lower part of the heart near the front and on the left. That is the basal anterolateral part, and that had 6 children's, that part of the heart was affected. Then if you see here 12, that is 31, so 5 children. So actually here this was 2, the number is 6. Number 12 had 5 children, so 12 is mid anterolateral. So anterolateral, anteriorly on front, and then on the left, and then in the middle of it. So anyways, they've given exactly which children, how many children had which part of the heart involved and inflammation occurred there. And finally, management. They said all the children received NSAIDs, 10 milligram per kilogram body weight, ibuprofen every 8 hours. 4 patients were not sick enough to continuously give this or give this in this periodic fashion. Instead, they were on as needed basis. 2 patients were given IVIG plus corticosteroids. Out of these 2, as I mentioned before, one of them had a resolution of the cardiac abnormalities, one did not. They had left ventricular dysfunction, so their left ventricle did not pump correctly, and so they gave them steroid plus IVIG. Then one patient had IVIG only, and even in this one patient, the abnormalities had resolved while they did not resolve in the remaining NSAIDs. Median hospital length of stay was 2 days. Range was 1 to 4 days. They were discharged, the children, when they did not have chest pain and their troponin levels were downtrending. Downtrending means no more cardiac damage was observed or inflammation was observed. No more troponin was spilling out of the cardiac heart cells or cardiac muscle cells, and so they could go home. LGE, this is what I've discussed before. LGE resolved in patients on IVIG plus corticosteroid, but not in others. No patient received cardiac failure medicine. Follow-up would be occurring in a year. And then they said that some studies have talked about the vaccine dose. And I have already gone over these pointers. Notably, in our cohort, though there was significant reduction in LGE at follow-up, abnormal strain persisted for the majority of patients to follow up. Now, this is not viral strain. What they meant was, this is the strain. So we have, let's say, left ventricle, and this is the circumference, right? And this is the length. These are called strains. When the heart would, these length and circumference is not called strain, but when they change, that is a strain. So as I said before, they look at the length of the ventricle before it starts contracting or near the end of diastole, and then they look at the, so let's say when the heart actually squeezes to pump, it becomes shrunken. That is how it pushes the blood out. And now they look at the length at the time of maximum shrinkage. And then they look at these 2 parts and look at their fraction, and that is a change. And they said this change was not occurring like a normal, regular change. So heart was still not contracting fully, you can say in a rough language. So abnormal strain persisted for the majority of patients in follow-up. Then they say further follow-up assessment and large multi-center studies are needed to determine the ultimate clinical significance of persistent CMR abnormalities in patients with post-COVID vaccine myopericarditis. So this is the discussion. Thank you very much for your time. if you would like to support this work, and I think we should do this work more, as much as there are censors and as much as there is a an attempt to stop these voices, I think we should continue to do these talks and present them. And this is actually a study from Children's Hospital. It's nothing that should be stopped. But anyways, if you'd like to support this work, there is a link in the description. Dr. Bean's premium account is so low in price that you will be amazed. So check that out. In addition to that, there are links. You can buy me a coffee if you would like to support this work, or you can use PayPal, or you can become a patron. Thank you very much. And if you like, subscribe, and share as well. So I'm going to now come back. We can do a discussion in a chit chat on the other channel. So I will see you on the other channel. If you would like, I can actually very quickly give you the link to the other channel. So one quick second, please. I'm just bringing it up. So here is the link to the other channel. I'm going to very quickly share with you the channels. Over the weekend, I drew this. So I was inspired by an image in another video, but then I sat down and I drew these cool beans. And this is the channel where we will go live in a few minutes. The link is in the description. And once again, support this work if you can. Thank you very much. See you soon.